Thank you all for having me today. Talking about a topic that a lot of you have probably heard about this weekend. So we'll go a little quickly through the beginning part, but I'm coming to you from Johns Hopkins, where, as you've probably heard from some of my wonderful colleagues, that we have a perioperative pain program. And what we're trying to do is tackle the opioid crisis, but also individualized pain treatment for patients around the time of surgery. So the moral of the story, I'll cut to the chase at the beginning, is it takes a team. We can't do it alone. And that means a team of researchers, a team of doctors, and a team of multidisciplinary colleagues that we continue to rebuild, reassess, and work with to help patients. So this slide is busy, but I'm also not going to go through it because you all know about the opioid epidemic. This is not news. This is not something that I want to belabor, but a few key points are the vast numbers that are quoted right now in the substance use literature about how many individuals in the United States have an opioid use disorder. And in 2020, that was 2.7. And then, as many of you have heard, since the pandemic, there has been an uptick in opioid-related overdoses, specifically synthetic opioids. So this is fentanyl, and it's several derivatives that are often laced in what patients, which substance users often think of as heroin, but it's really mostly fentanyl and its derivatives at this point, which can cause a great deal more morbidity. When we talk about the opioid epidemic, we think about opioid abuse and we think about overdose deaths, and those are the numbers that are commonly talked about. However, there are a vast majority of Americans who are compliant with their chronic opioid prescriptions, whether that's in the short term around surgery or over several years. Now, the pendulum is swinging the other way, but it is important to recognize that the physiology in the body doesn't care whether you're doing an opioid for euphoria or if you're trying to manage your pain. So I think that's one thing that I just wanted to touch on during this intro. And what we care about in the acute pain realm and the perioperative pain clinic is how do we mitigate some of the opioid exposure to these patients around the time of surgery. So several landmark papers have come out over the last several years showing that new persistent opioid use can be found in between around 6% of our patients. And those are patients who are naive. Those that are on opioids prior to surgery have an increased risk of being on opioids longer term at higher doses. And the graph on the right shows that the number of days supply of prescriptions that a patient is given after surgery actually can predict with some degree of certainty that the longevity of their opioid use. Whether that's a disorder or not, this is still important for all of the complications and side effects that we know about, not just respiratory depression, but also endocrine disorder and inflammatory states. And so it's important to think about not just those who are misusing opioids, but those that are using them as directed, and how can we help them better? So one thing that the literature has taught us is that there is sort of a gap between after surgery. Initially, the primary team in a surgical patient is the surgical team prescribes the opioids at discharge. And then sometimes they will come back at a follow-up visit and get another prescription. But typically the surgeons fall off on the prescribing of opioids within the first 3 months. And then it's left to all of our other physician colleagues to pick up the pieces, whether that's primary care doctors who are now handed back a patient on a much higher dose or a new opioid, and they may or may not feel comfortable managing. And often this also involves emergency room visits. So what Hopkins recognized early on in 2016 is that pain is the #1 reason for ambulatory post-surgery readmissions, that we're not managing their pain in the acute realm. And of our over 60,000 cases, there were several cases that were complex, leading to higher risk of this readmission and chronic pain or chronic persistent opioid use. So in 2017, Dr. Hanna, Dr. Speed, Dr. Schechter, and a great team of individuals developed the Johns Hopkins Perioperative Pain Program, which again, you've probably heard about during this conference. Our goal is to see patients preoperatively to optimize their medications, just as if you were going to optimize someone with heart disease or diabetes prior to a complex surgery, and to adjust multimodal medications and also expectations and a plan for the future, and then hand those patients off to the inpatient acute pain medicine service, who then can employ multimodal techniques and infusions such as ketamine, IV lidocaine, some of the other things that you've heard about this conference, as well as regional techniques. And then the majority of the patients actually are followed post-discharge, post-surgery in the perioperative pain clinic to help decrease their new acute opioid amount. And what we have found, teaser, we're able to taper these patients down from their opioids. So this is based on a consult system, which there are many different types of referrals. Typically, our surgeons are referring a lot. There is self-referral, PCP referral. Substance use disorder teams can refer if they know that patient's going to have surgery. And again, we don't have hard cutoffs for all of these things. We take whoever needs us and try and fit them in so we can help them. So a pause for audience participation. I had hoped we would have a clicker system, but unfortunately that wasn't available. So I'm going to go old school and ask for a show of hands. So what teams exist at your home institutions? Everyone who only has an acute pain service, raise your hand. Oh, that's good. Okay. What about an acute pain service and a substance use disorder service that's inpatient? Great. And what about an acute pain service plus or minus a substance use disorder service, as well as a perioperative transitional pain clinic? Okay. Great. So all of the above, I know we're lucky to have that at Hopkins, and that's part of our interdisciplinary team that we're working together to help these patients. Does anyone not have an acute pain service? Sorry. Well, maybe we can leverage some things to help convince them. So as I alluded to earlier, we've seen a lot of strong improvement in these patients over the course of the perioperative pain clinic. And what I didn't go into was the nitty gritty of what we do at the perioperative pain clinic. And predominantly that is Dr. Schechter and Dr. Hanna seeing the patients and working based on what they knew before surgery, what the APS team, surgery team, substance use disorder team, inpatient discussed, and then taking that one step further to try and help patients. Now, we also are very lucky to have a psychiatrist, Dr. Tracy Speed, as part of our group that helps with behavioral pain management and building coping skills. And what we've seen over this early data is that we are able to significantly reduce the milligram morphine equivalents in these patients at about the 3 to 4 month mark. This is even improved if our patients are seen pre-surgery, and that's a pathway that we're trying to strengthen. We do see that there is a significant improvement in physical function and mental health surveys as well. And unsurprisingly, the pain scores don't change significantly at first, but we're still looking into that. And again, the way we check pain scores, even the brief pain inventory is not perfect. So really functional goals is what we're trying to aim for. And the next part that I want to talk about is my interest in substance use disorder patients at this intersection of perioperative pain management. And our initial group of PPP patients, perioperative pain program, 11% of them were on a long-term medication-assisted treatment for substance use disorder. So I'm going to briefly go over that, and going into the details of the different treatments is beyond the scope of this talk. But medication-assisted treatment, and there's many different ways that this is abbreviated in the literature, but it used to be called MAT, sometimes now called MOOD, as medication for opioid use disorder. Regardless of what you call it, it is a program that is helping to decrease craving in patients, at sometimes also treating pain, but giving them a support system. Hopefully that's a buprenorphine prescriber that also can refer them to other providers like psychological support. And methadone clinics, as you probably all know, have a required component of group therapy and interventions. So this has been proven over the years to be the gold standard of treatment, despite the fact that it's switching the opioid and still maintaining some opioids. It has been found to be superior to behavioral interventions alone to prevent relapse and overdose. And just for a scope of how many of these patients are presenting to surgery. Between 2018 and 2019, over 400,000 US citizens were on methadone, and over 1 million individuals had a prescription for buprenorphine. So it is a large amount. So we are seeing these patients coming into the pre-op area, coming in as a trauma. And unfortunately, as you all probably are aware, this is an area, because they are complex and hard to follow at times, this is an area of research that is sort of missing. We exclude the patients with substance use disorder often in our perioperative pain protocols, in our ERAS protocols, because we don't know their data as well, and it's much more messy. So the next thing I want to touch on is what we do with their medication-assisted treatment around the time of their surgery. So this is a always changing discussion and controversy. And again, because there's not great studies on this yet, a lot of it is expert opinion. So none of the answers are wrong before you start raising your hands. So how do you manage perioperative medication-assisted treatment? Do you stop them regardless? Anyone? Always stop them. Continue methadone. I know there's A, B, and C. Because I didn't have the clicker, go ahead and raise your hand for any that apply to you. Do you stop perioperative buprenorphine if possible? I love this audience. You guys read the guidelines, so this next slide's gonna be easy. How about tapering the buprenorphine or switching to an acute opioid agonist? All right, A+ audience. And then as you'll see, the guidelines recommend continuing buprenorphine at the home dose. And these are the new guidelines based on a consensus study published by Lynn Cohen and through ASRA and several other societies that talks about what the evidence is for continuing buprenorphine. Methadone is easy to continue because it helps with pain, and they're usually stable on a given dose. As you know, on that prior slide, I showed that buprenorphine is a partial agonist, so there is a risk for a ceiling effect where their pain can be more difficult to treat because the opioids we're giving them in the perioperative period have to compete with the strong binding affinity of buprenorphine at the mu-opioid receptor. So just quickly going through this, since you all know the answers already, there is moderate evidence to suggest that you should continue buprenorphine at the home dose if possible. The reason for this is not that it's a superior pain medication, but that the risk of not restarting it and leaving these patients in some sort of limbo at discharge is very dangerous. And there are several studies to show that around the first 30 days after surgery is the highest time for opioid use disorder relapse and overdose. And sometimes this is because they were on a stable medication course and that was altered in hopes of providing perioperative pain control, but ultimately leaves them without the tools they need to battle their ongoing substance use disorder and pain. And then postoperatively or perioperatively use multimodal analgesia. That's obviously something that we're all doing and talking about at this conference. And if you're going to consider using a short-acting mu-opioid agonist, fentanyl is the second highest affinity that will compete, and Dilaudid as well. So those are superior to morphine in this situation. And then there are some evidence in these guidelines to consider increasing the dose of buprenorphine as you get closer to discharge for pain control, or splitting it. So just like methadone, the analgesia timeline is shorter than the cravings timeline. And then if their dose was changed, the most important thing is to make sure there's a warm handoff to someone that's going to restart it, whether that's through a microdosing with their substance use disorder team to prevent withdrawal, or handing them back to their clinic to help transition them back. So this brings me to what I've been working on. So as I mentioned, my interest is the intersection between substance use disorder and perioperative pain. And I was lucky to be invited to join the PPP research group at Johns Hopkins. And early data that we have seen shows that in a pilot study of 340 subjects between 2019 through July 2021, we were abstracting from the postoperative PPP visit notes their morphine equivalent MMEs over time. And the majority of PPP patients were able to have their opioids decreased, as I had showed in the previous slide. What we were curious about is, are those on methadone or buprenorphine at a disadvantage? Are we still able to taper their opioids. And then the next steps are going to be how do we do it more effectively? How do we catch more of them? But the good news is that we have seen early on here that there is the possibility of tapering opioids in this more complex patient population that hasn't previously been well studied. So overall, what we see is that in those on medication-assisted treatment, 35.7% were actually tapered from their acute new opioids down to 0. That is not saying that we took them off their methadone or buprenorphine. That is excluded from that morphine equivalent calculation. And another almost 46% decreased their morphine equivalent significantly. And only less than 4% had no tapering whatsoever. This is reflected similarly in the non-MAT population. And overall, we're seeing a robust improvement in opioid concentrations and usage by the time they leave the perioperative pain clinic. So again, this is early work that we're very, very excited about. There are a lot of questions to answer. What is the time course and what is the natural history of patients on methadone or buprenorphine around the surgical period, and how do we improve that? How do we improve their pain control? And how do we make sure that we're capturing them and getting them engaged in these programs that will help them? So with that, I'd like to open it up to questions, and thanks to everyone in the perioperative pain program team, Dr. Hannah, Dr. Speed, Dr. Schechter, Dr. Z, and our statistician, Ejen Su. Thank you.